Hi, I'm Dr. Brad. We're going to open this topic up on Lyme disease by answering a question that we put out to different Lyme forums on what they would really like to be addressed as far as the topic matter goes. And this was leading into putting together a book on Lyme disease. And the universal response we got was no one's really addressing in a functional way this problem of hormonal dysfunction, hormonal dysregulation, and sexual dysfunction. I'm going to talk up on this subject. It's quite an interesting subject. When we look at men and women, we both look at ourselves quite differently. Women are a lot more negative about themselves. Men are a lot more positive about themselves. Women tend to look at themselves to be not as attractive as they really are. They look at themselves as if they're fatter than what they really are, where men looks at themselves commonly in very much the opposite. They feel they're more attractive, more masculine, more in shape than they possibly really are. Why that is, nobody really knows. It is something that we do notice, though. And if we start to look at the anatomy of the reproductive system, and that's correct, a woman's anatomy here, it's easier to start with. And it really makes things make a lot more sense when we follow this. When you look at this, the uterus is coming up through the middle, the fallopian tubes wrap around, kind of hold like this, and the ovaries are kind of like a beach ball that the fallopian tubes would hold in place. The round ligament, it wraps around through the fallopian tubes, across the ovaries, across the top of the uterus, and holds the whole reproductive system up tight and close to the bladder against the anterior abdominal wall. If we look at a fetus after conception, male and female fetuses are basically the same till about 7 weeks after conception. After the 7th week, if the fetus can be male and the testosterone rises up enough to start the differentiation, the ovaries grab the round ligament, drop down through the inguinal canal, which is in the lower part of the abdomen, drop down into the labia. The ovaries become the testes, the round ligament becomes a spermatic cord, and the labia becomes a scrotum. And if you notice the seam on the bottom of the scrotum, that's where the labia fuse together at that point in time. The uterus, then, it drops down, wraps around the base of the urethra right next to the bladder. That becomes the prostate. And the clitoris, the rectal part of a female's genitals, that both men and women have 3 cruxes, or 3 parts of erectile tissue that differentiate. A woman typically has 1 crux in each one of the labia majora and 1 in the clitoris. Those 3 come together, wrap around the urethra, elongate, and that becomes a penis. So from an anatomical standpoint, we're really pretty much the same. And from a hormonal standpoint, it's really important to know this because the same hormonal problems that women have with their reproductive anatomy has that exact counterpart in male. So yes, we are talking about the same thing. We're not just favoring one side. This is looking at the female anatomy from the side view, and you can see the uterus comes up and the fallopian tubes are kind of up above the top, holding down like this. And right in front of that is where the bladder is. That's where the uterus drops down, wraps around the base of the bladder, and becomes a man's prostate gland. So if we look at the different female hormones, we have estrone, estradiol, and estriol. Estriol is the primary hormone that floats around when a woman is pregnant. It's the gentlest of all of the estrogens. All the estrogens create enlargement of tissues, increase of secretions, but it's kind of an inflammatory hormone. The estrone is the one that is most common postmenopausal and perimenopausal. That one can cause cancer, breast changes, fluid changes, cramps. It's typically the estrogens that create the migraine issues. The estradiol is the one that's most common when women are cycling. It makes the uterine lining grow, secretions increase. It's primarily responsible for the engorgement side of the cycle, breast changes, and menopause is pretty low but in constant levels. So when we look at those, all of this is supposed to be calmed down with progesterone, and we have this cyclical thing that goes back and forth. We'll get to that in a bit of a minute. But when we look at estrogen replacement therapies, things like Premarin, birth control, all that, it starts to really screw these hormones up in the uterus. And all the pharmaceutical hormones, and that's pretty much where the contraceptives come from, the birth control pills, and also the same type of thing for women who are supplemented postmenopausal. Those don't come from a human source. They pretty much come out of horses, and the horses' fractions of estrogens are not like humans. They're hyperinflammatory, and they create all these different problems that go on. So if we look at commonly in the cyclical side, the effects of estrogen and progesterone, estrogen pretty much causes the tissues to engorge, to grow, and secrete, which creates an inflammatory problem. The progesterone comes in on the second half of the cycle after ovulation, and it just tells everything to calm down. It's going to be okay. And it starts to become a real problem when these hormones don't cycle back and flow with the ebb and flow and cancel each other out. So this is looking at how the hormonal cycle works. We have the same hormonal cycle in both men and women. It just functions a little bit differently. The women seems to be a little bit more complex, but it's really not. It's one that people study the most because women tend to have more cyclical problems, and they're a lot more aware of those, and they need to be addressed in a different way than men do, because men typically just don't address things. They'll kind of ignore it unless there's a fertility problem, and then it becomes an issue. So if we look at this slide right here, the hypothalamus, it's just right above the base of the brainstem. And it's what detects the levels of hormones, gases, nutrients, minerals, things like that without the body. And it sends signals to all these different organs to help control everything. Right in front of the hypothalamus is a pituitary. The pituitary communicates out with most of the glands that create hormones. And in this case, we're going to look at the hormones for the gonadal responses. There's a hormone that starts to go out called follicle-stimulating hormone. And within the ovaries, women have a certain amount of eggs in their ovaries, and there's the cells that line around those eggs that become a follicle. When the FSH, or follicle-stimulating hormone, starts to rise up, it tells some of those cells around the eggs to start to develop, and make a follicle. And what they do is they grow, they start to secrete. Those secretions make the eggs be bathed in this fluid, and that follicle is going to burst upon ovulation. If that's going to happen, several of those will start to develop at the same time. The one that wins the race, actually, when it releases, the other follicles are developing, will be just absorbed, and they won't continue to develop in most cases. Sometimes with twins, that will be. As the follicle starts to develop and grow, it starts to increase the estradiol. And as estradiol goes on, women start to have the thickening of the uterine lining, different things like that. When the estrogens start to rise to a certain point, the hypothalamus registers this certain level of estrogens and goes, oh, we're finally ready. So it releases another hormone called luteinizing hormone. Luteinizing hormone says release the egg, and whichever follicle is ready, that bursts. So it literally makes a cyst, and it bursts, and the fallopian tube is supposed to catch that. So the cycle of creating cysts in the ovaries and having them burst is a normal way that women cycle. It's just the way they were designed. Once that follicle bursts and lets the egg out, it changes and becomes a grafting follicle, and the grafting follicle starts to make progesterone instead of the estrogen. It's typically at mid-cycle, right around day 14. The hormones start to shift right at that point in time, and as that hormone starts to shift, the progesterone tells all of the blood vessels in the base of the uterine lining to clamp, shut off. It stagnates the blood. The blood becomes a very rich environment for implantation. And if there's fertilization and implantation, fetus can start to grow in a rich environment until it creates placenta, and things go on along that way. So that's typically how a female cycle occurs. In a male, same thing happens. Follicle-stimulating hormone goes into the gonads, testicles. It tells it to develop sperm. Luteinizing hormone allows that to be released, and that gets stored, and if there's ejaculation, that gets released. So, same organs, same hormones, same responses. This is a view of what goes on within the uterine lining as the follicle starts to grow. The uterine lining thickens, it becomes highly vascular. Once the follicle bursts, the progesterone comes up, the blood vessels clamp off, make the environment very, very rich to grow in, and if there's a implantation, it'll stay that way, revascularize, and go on. We have a very similar cycle going on with this in men, but it's not in a monthly cycle, it's just more continuous. So when we look at hormone balances, there are several things that will balance those and help those out. Our food, that determines inflammatory status, toxic loads, things like that. Our gut. Our gut's a very intricate organs full of nerves. It has a host of microbiota called the flora in it. There's more bacterial cells and then microbiota, and there are human cells in the rest of the body, and that's only counting bacteria. That's not counting yeast and molds and viruses and things like that. So there's way more microorganisms growing in the lining of the gut than there are human cells in the rest of the body. The gut controls hormones through that. That microbiota makes every hormone that we have. It makes every neurotransmitter that we have. It determines the detoxification pathways of those. It determines whether we excrete or recycle our hormones. Just inside the lining is a rich supply of nerves. It's called the enteric nervous system, and actually controls the brain function, and it's really pretty intricate. All the blood from the gut, it drains in the liver, and the liver is supposed to detoxify things. It's supposed to be this immune catch-all. Then anything that leaks through the gut, the liver is supposed to be able to catch that, deal with immune responses, and it also addresses blood sugar when we're really stressed out. The HPA, which there's a lot of press about the HPA axis, that's the hypothalamus, pituitary, adrenal axis, and that's only part of our hormonal regulation. We need to add with there the T, which is thyroid, the G, which is the gonads, testes or ovaries, the pancreas, it creates hormones, the pituitary creates growth hormone, some other things along that line, and it's this whole catch-all of regulation that goes on. There's a lot of press about the HPA axis. Adrenal's huge as far as the control of that because there's so many hormones that come out of that. The adrenal actually makes all the precursor hormones for the gonads to build our sexual hormones. The adrenal puts out DHEA and pregnenolone, which that goes into the gonads and the peripheral tissues. Once we get older, menopausal age, we're older, and then almost all of our sexual hormones are made in peripheral tissues. So not necessarily the gonads, that can be in the breast tissues, the other reproductive tissues. A lot of that goes on in the muscles themselves. And when we look at this, the main concentration is in the adrenals and the pituitary. It's because most people don't know how to deal with the hypothalamus. But the hypothalamus is what registers all the levels of everything. And something that we've been finding is that the hypothalamus is really oftentimes the primary issue. And what most will try and do when they start to dysregulate, they'll try and throw hormones at it, whether they're bioidentical, horse origin, or pharmaceutical. They'll try and throw hormones at it, and it's actually kind of a nuts thing because it dysregulates the whole HPA axis. Because everything works by the hypothalamus registering what's there. If we fill ourselves full of foreign hormones, the hypothalamus can't register what's there. There's no way to regulate what's going on. It's a really good way to chemically kill our glands that make hormones. And that's commonly what happens. When the toxic load is too high, the same thing happens. It just destroys this feedback regulation. In a natural sense, most people are throwing adaptogens at the whole system, but adaptogens don't address the real issue. And they'll never solve the problem. They can't, and they don't, because the mechanism isn't right. What commonly goes on with the whole dysregulation is this whole issue of toxic load, and whether those toxins are things we're making inside, whether that's from disrupted microbiota, the flora inside the gut, whether that's from chemical loads in our environment. Molds will do that. Petrochemicals will do that. Once people start to have flora problems, they start to have problems with all kinds of scents. Those will do that. One big thing we've really been running into is dryer sheets. Dryer sheets and fabric softeners are actually more toxic than some of the worst car paints that are out there. They're extremely toxic. Those will disrupt the whole HPA axis. Toothpaste, anything with SLS, sodium lauryl sulfate, disrupts the whole HPA axis. There's a lot of different things that can do that. You can't just throw something at it because it doesn't work. You have to figure out what's causing all that. The thyroid, when we put this in there, because I added that with HPA axis, HPA-T, that's typically where we get all our energy is half of a woman's cycle. The thyroid actually controls how many and how big and how active the mitochondria are in all the cells in our body. The mitochondria are what make energy in every cell in our body. Without energy, we can't heal, we can't do anything. Nothing functions. The pancreas, it makes insulin, which is trying to regulate blood sugar, but most of our blood sugar regulation actually happens through cortisol in the adrenal gland. The pancreas also makes alcohol. Alcohol gives us our temperature regulation. The gonads give us our sexual hormones also. So we look at the whole hormonal interaction. It's really intricate, and it's totally interconnected. The thing that registers how much of that we have going on in our body is the hypothalamus. The pituitary communicates with the hypothalamus on what levels things are, and the pituitary sends signals out to all these different organs on how much to put out in one way or another. So, as I said a little bit ago, once we get older, almost all of our sexual hormones, male and female, get changed and converted in peripheral tissues. And it's basically through the adrenal hormones, DHEA and pregnenolone. So this is something called the pregnenolone steal that happens just consistently in people with chronic illness, chronic stress issues. The pregnenolone, as I said a little bit ago, it's one of the precursors to make our sexual hormones. And the progression is pregnenolone, DHA, convert into first progesterone in both men and women. Progesterone then converts into testosterone in both men and women. And testosterone converts into estrogen in both men and women. If we're too stressed out, and anything can be too much stress. Chronic illness is absolutely too much stress. Instead of the pregnenolone and the DHEA going to the gonads and the peripheral tissues to make our sexual hormones, it goes back through the cycle, gets converted into cortisol to try and deal with the stress. And the cortisol is there to try and help us defend our lives. And with chronic illness, everybody that's there understands it is a fight for your life. So this is what happens with pregnenolone steal. And then we add some other issues. Whenever the cortisol levels rise, cortisol will raise the blood sugar. When the blood sugar rises, insulin comes in to try and get the sugar out of the blood into the tissues. That will start to put on fat layers, basically everywhere. There's well over 20 different hormones that occur inside of fat. Cortisol and insulin together, when those start to rise, it turns on a hormone in fat called aromatase. The aromatase takes the circulating testosterone in men and turns it into toxic estrogen. That's right. Toxic estrogen. And effeminize them. Their genitals will start to shrink. It's part of what goes on with man boob formations, different things like that, but libido really falls through the roof. Genitals start to shrink. Same thing occurs in women. Their genitals can start to atrophy quite a bit because they're not being nurtured by the sexual hormones. And their estrogens can get converted into testosterone on one side and toxic estrogens on the other. So it's really quite a big deal. Years ago, I was at a conference where somebody brought up a website that was used as a marketing model for just how creative it was, and it ended up being a plastic surgeon site. And I pulled that up, not knowing where I was going, and I'm looking through the guy's site, and things made sense, the breast lifts, the face lifts, things like that, but I got to a section and talked about labial lifts, and that puzzled me. And it really puzzled me. Why would that occur? And it took some head scratching to figure that out. But I realized something at that point in time. Once I did figure that out, it's because of hormonal depletion that goes on in women as they age, hit the menopausal age, or when they have chronic illness. They start to have labial atrophy, and those will start to droop, and women want to lift those up to look young and feminine once again. And wow. And I started putting a few things together. The erectile tissues, pretty much they work off nitric oxide. Nitric oxide makes them both engorge, and with a woman, the clitoris, it engorges, it erects, and that can make contact with sexual intimacy. That's the one. When the other two cruxes engorge, that engorges the labia majora, and that opens up the reproductive tract for intimacy. So when we start to see things like this going on, we have this complete dysfunction that's happening in women that's completely ignored because they can still engage sexually even though their organs aren't working right. And when they don't have the engorgement in the erection, the clitoris doesn't erect and they can't engage the clitoris with the action of intimacy, and they start to lose their ability to have orgasms, and with the inflammatory process starts to become very, very painful, the whole issue of sexual activity. So this is really, really a big problem. It's huge, and it's something that needs to be thrown out in the open. It is addressable, but it's not something you can throw a pill at. You have to really look at what's creating the whole nightmare and undo it backwards. So if we look once again at the idea of throwing hormones at it, hormones, estrase, ethanol, estradiol is about 100 times more toxic than the worst hormone that women can make. It creates cancerous growth, cancerous lesions, things just grow out of control, and it's not the right way to do it. It's just not the right way to do it. Anytime you throw hormones and hormone dysfunction, it dysregulates our ability to regulate it. It disrupts the HPA axis. And once you do that, you cannot bring a normalcy back until you pull that off. So when we look at the warning label in Premarin, estrogens, they increase the risk of cancers. Fairly obvious. And that's going to be the case with any artificial hormone replacement. It's an unchecked, unregulated, hyperinflammatory response that's going to go on within tissues, especially the soft tissues, the sensitive tissues, the sexual tissues, breasts, reproductive systems, things like that. And when we start to look at the intimacy issues, the bacteria within Lyme disease are small enough. There's pores in condoms. They're small enough to go through the pores. We go through this a little bit later, but the Lyme bacteria, along with the co-infections, have been found in the sexual fluids of men and women. So you can transfer this. It's a sexually transmitted disease. Any body fluid transfer can create all this issue, and that's another side of the problem. What do you do with that? Condoms don't really offer the protection because they have pores in them. HIV can go through the pores, and so can some of the Lyme bacteria that are there. So it's a real needed problem. And when we look at the root issue of all this, we need to understand the mechanism of chronic illness. When we look at it, first, with a chronic illness, things don't heal by themselves. They're not self-limiting. They're not like a cold. They're going to last a certain period of time and go away. It just doesn't happen. Second, the chronic illness, they get worse over time. And anybody with Lyme disease or any chronic illness knows that's absolutely the case. Third, there's not one single cause that starts everything. There's usually multiple causes. And fourth, by the time, or we'll add to the third one, not only are there possibly multiple causes, but by the time somebody comes to some place to finally get care, whatever started in the first place may no longer be there. And the body processes are just on autopilot and it is an inflammatory nightmare of being totally out of control. And the fourth thing is these are all complex interactive things that you can't just isolate an issue. You have to see how everything's going on, how it's interacting, what's causing what, and how you can unwind the whole thing. Without there's not a magic bullet for this. This is absolutely totally addressable. But the way you address this is by addressing the individual's needs of what's going on with their body systems to restore these things. And that really makes sense. So, with that, we're going to end this talk, and then we'll go on to the next one.